Muy buenos días para todos. Solo vamos a dar un minuto para que se terminen de incorporar otros participantes que aún están ingresando. Good morning to everyone. We're just going to give you a few minutes so other participants can be incorporated to the session. So just give a couple seconds. Bien, muy buenos días para todos y para todas. Bienvenidos a este webinar. Solo para dar una información de referencia, en la parte inferior de la pantalla tienen un botón de la interpretación y ahí pueden elegir la interpretación en inglés o en español dependiendo de su preferencia. También la parte inferior de la pantalla tienen un botón de Q y A para hacer sus preguntas durante el desarrollo de la sesión y que luego pueden ser planteadas a los panelistas. Good morning to all. Please use the interpretation button in the bottom of your screen to select your preference for English or Spanish translation. And then you will also have the Q&A button in the bottom of your screen to make questions and questions during the session. And they will be made to the panelist or to the at the end of the presentations. Okay, so now I'll give the word to Leo Netherbean, who will be doing the opening remarks.
Thank you very much, Luis. I'll do the opening remarks on behalf of Dr. Hennes, who unfortunately has another important meeting where he has to attend. So welcome everyone. Good morning to all, and thank you for participating in this webinar. Non-communicable diseases, particularly cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases are responsible for almost 80% of all mortality. NCDs can be prevented by reducing their main risk factors: tobacco use, harmful use of alcohol, unhealthy diets, and physical inactivity. The WHO Best Buys are powerful tools for the prevention and control of non-communicable diseases. Several of the interventions recommended in the WHO Best Buys include mass media campaigns, implemented as part of a comprehensive set of policies instead of isolated interventions. In this context, mass media campaigns have been used to create public awareness, to change social norms or advocate for regulatory policies, for behavior change, for sodium intake reduction, or to warn the population about the harms of smoking or tobacco use and secondhand smoke. On the other hand, marketing has been used as a tool to persuade people, particularly for commercial applications. For example, food marketing predominantly promotes foods high in saturated fatty acids, trans fatty acids, free sugars, and/or salt, using a variety of strategies affecting people's choice and ultimately consumption. However, marketing can also be used to create positive social change through social marketing, which can be defined as the use of commercial marketing techniques to achieve the common good. The Pan American Health Organization, together with the WHO Collaborating Center on Social Marketing at the College of Public Health, University of South Florida, and with the financial support of the American Heart Association, launched in July 2020 an online program on social marketing for public health as a tool to build capacities in public health professionals in developing and managing social marketing campaigns. The program is offered in English and Spanish as a self-learning or tutorized modality, and is hosted by PAHO's Virtual Campus of Public Health. The curriculum consists of a self-learning course, Introduction to Social Marketing for Public Health, followed by a second course, Planning and Development of the Social Marketing Program for Public Health, of 4 modules. Upon completing the two-course program, participants will be able to direct or supervise social marketing programs in their territories. making informed decisions and apply a systematic 5-stage process that ranges from problem formulation to monitoring and evaluating the plan. More than 16,000 participants have registered for the introductory course. Additionally, a cohort participated in the Tutorized course guided by a social marketing specialist, both in English and Spanish, and developed proposals for social marketing campaigns. The topics selected are related to decreased sodium intake, decreased consumption of ultra-processed foods and sugar-sweetened beverages, promotion of physical activity, and tobacco use, among others. Social marketing campaigns have to be implemented together with actions to modify the environment, making the healthy choice the easy choice, especially among children and adolescents, as well as their caretakers. During this webinar, we will hear an overview of the program from the director of the WHO Collaborating Center on Social Marketing and from the participants of the Tutorized modality from Aruba, Costa Rica, Panama, and Sint Maarten. They will share their experiences and lessons learned in the program, and particularly the development and implementation of the proposal for a social marketing campaign. So welcome all of you to this session. This is the first webinar we organized after we launched the program 3 years ago. So first we are going to see a video that has been prepared 3 years ago to disseminate this program of social marketing for public health. And just to mention, this program is still open for anyone who would like to participate. We will share the links with you. So let's first have a look at the video that we prepared 3 years ago. I can't hear the sounds. I'm not sure if everyone has been able to hear the audio. At least I couldn't. But if not, we will try to show the video later during this webinar. For now, let's move on with the agenda. And our first speaker is Mahmouda Pasha, and she is the director of the WHO Collaborating Center for Social Marketing at the University of South Florida, at the College of Public Health. So she will give us an overview of the program on social marketing for public health and its implementation. We have been partnering with them in the development of this program. So welcome, Mahmouda. I hope you're not much affected by the hurricane, and you have the floor.
All right, thank you very much, Leo. Good morning to most of you. Yes, we are fairly safe here in the Tampa area, but the hurricane is hitting the northern parts of Florida, so we're hoping that they remain safe as well. The purpose behind my presentation today is to really share with you an overview of the program that we implemented, also to provide you with a history of our center and our relationship with PAHO, and then to transition it into the presentation that will be given by some of our country partners and the work that they accomplished over the course of the last year that we've been implementing this. So if you can go to the next slide. So as Leo shared with you, my name is Mahmouda Khalik Pasha. I'm an associate professor of social marketing at the College of Public Health at the University of South Florida. As part of my responsibilities, I also serve as the director for the WHO Collaborating Center on Social Marketing. And the reason we have the center established at the University of South Florida is that we have we've been held in high regard around the world as a center for social marketing at the University of South Florida. We're one of the only academic programs that exist in the world where you can come and get a master's degree or a certificate or a PhD in social marketing. And we've had multiple centers. And due to our work in the field of social marketing, the WHO recognized us as an expert on this area. And in 2014, we were designated as a center for the WHO. And we have since been redesignated in 2018 and most recently in 2022. As part of this designation, we've collaborated with PAHO as well as many of the country partners in Latin America on multiple projects. So we can go to the next slide. The mission of our center is to address the growing problem with the non-communicable diseases by capitalizing on the strengths of social marketing coupled with social change strategies. The center of our focus, or the main pillars around which we focus our work, are related to training and technical assistance, and then also building capacity and knowledge exchange in the region. Next slide. So we have a long history of working with PAHO and in utilizing virtual platforms to educate the public health workforce. So the development of the courses that I'm going to present with you and the screenshot that you see here is just one part of it. But we've been collaborating with PAHO through our social marketing conference, which is one of the longest running social marketing conferences in the world, and the training academies that we provide. We've been previously using the Carmen Virtual Public Health Network that PAHO had as a way to provide online education. And then now most recently, we've been using PAHO's Virtual Campus for Public Health to host this new course, as well as the courses that we've developed for them before. Another collaboration that we had with PAHO, as well as many partners in the Latin America region, was a project that we had funded through the International Development Research Center, and we work with 5 country partners, one of which I think you'll hear from today, as well as they're one of the presenters for this webinar. Next slide. So some of you may not be familiar with what I mean when I say social marketing, or when you heard the word social marketing. So I wanted to give a little bit of an introduction to what is social marketing, so that way you have an understanding of it prior to us going forward in talking more about what we actually went about doing. And so basically, as we know that we're facing very complex challenges, and in order for public health professionals to be ready to address those challenges, that they need to be aware of more innovative approaches that are available to them. As Leo shared with you at the very beginning, social marketing has been listed as one of the best buys by the WHO and is one of those innovative approaches that can be used. Said shortly, social marketing is an approach to behavior change that uses traditional marketing or commercial marketing tools to promote sustainable and positive social change. So what does that mean? So what that means is that we focus most of our attention on really understanding the individual, the consumer, or the population, or the audience, really understanding them. So everything that social marketing develops is user-focused and developed with the user or the individual at the heart of it. So how do we go about understanding the user? We understand them by using research or doing listening. And once we have listened to them, we gain insights into why they do what they're doing, what would they like to get out of doing the behavior that we would like them to do. And using that information, we go about developing a marketing strategy to encourage them to make a change in their behavior. And this in turn results in a larger social good for us as a society. Next slide. So as I shared, that listening and research are the primary components of social marketing. So once we do the listening and research, it helps us to understand the person better or provides us those insights. And then we use those insights as a way to then target better from a behavioral standpoint, also to segment the population, meaning not looking at it from a one-size-fits approach, but focusing on the specific segment of the population, and then understanding what they're currently doing, and then using that information to develop a marketing mix. Today, as you will listen to the presentations by the panelists, you will see this come to fruition as they share the information that they embarked on as they went about tackling their public health topic. Next slide. One of the other things that I really wanted to emphasize is the relationship of the social marketing to this concepts of social determinants of health. Because sometimes I feel that they're not seen together as one and the same in some respects. For social marketers to be successful and for them to select a behavior that a product or a service that is applicable to their population, they have to look at it from a systems-based approach. So in unpacking the public health problem, understanding why it exists, we have to have a better understanding of what is influencing the environment and who are the influencers for the audience. And so in using the systems-based approach in unpacking the public health, we often understand how these social determinants of health are impacting the health problem that we're working with. And we often focus on those specific determinants as an initial step in guiding towards the behavior change. So we look at the systems-based approach. And one of the interesting things to note is that we often may think about behavior change as something that's done at the individual level, but as you will see in the presentations, that in order for us to have a change take place at the individual level, we have to influence the stakeholders, which is midstream, and we have to influence the decision makers, so the policy makers, that's upstream, because only when you get a change happening at those levels can it be easier for somebody who's an individual or the population to make a change at that level. So next slide. Another thing to note with social marketing is that social marketing moves beyond just mass communication or public awareness or to go about getting the behavior change. In relation to the issue of SALT, which is what you're going to hear about a lot, SALT reduction in some of the panelists' discussion, it has been noted by multiple researchers that we're not going to make a change on this topic if we only focus on education, because education itself is not enough to get the change in behavior. In order for us to get a change in behavior, we have to influence not only the individual, but we have to move upstream in relation to decision makers and policymakers. And what this can look like is that we can work together using social marketing to decrease the demand for salt or high salt products within the household, but we can also use it as a way to generate demand for low salt or salt alternatives. But that involves us working not at the individual level, but also within the larger policy environment. Now, next slide. So I wanted to give you kind of that background as to what social marketing is and the different levels in terms of where we intersect or we can interact. And now I want to move us towards talking about what we actually did. And so this program on social marketing, as it was mentioned, we launched this program in 2020. That's when we developed this curriculum. And the curriculum is 5 courses that we have, but it is designed for, public health professionals from around the globe to go about utilizing it. We've had many people, access this information, and then we've had some, which you're going to hear about, who've actually gone about using it with working with us in providing them the technical assistance. But what I'm going to share with you is work that we did in using this course in a tutorized manner, which is working with country teams from around the Latin America and the Caribbean region between July of 2022 and now at the current point that we're in. So next slide. The way we went about structuring this tutorized course is that we based it based on language. And so we had two cohorts that we had working simultaneously. We had one cohort that was from Latin America that was working on this course in Spanish. And then we had another cohort that was working on the course in English, and that was from the Caribbean region. And one thing to note is that when we created these cohorts, we asked the cohorts to be determined based on countries, like which countries they're focusing on. And then once the countries had formed teams, then we moved forward from them in terms of asking them to select a risk factor. So are they working on physical activity? Are they working on nutrition? What's the health topic? Do they want to tackle alcohol, tobacco? What's the public health topic that they're going to select? Once they had gone about selecting that, then we moved through the course itself in getting them through that. Next slide. The individuals who were providing the technical assistance throughout, I wanted to make sure I introduced some of my other colleagues who've been instrumental in guiding the teams through this work. So I was the lead for the Caribbean cohort, which was based on using English. And with me was Angela Macris, who's a PhD candidate in the College of Public Health at the University of South Florida. Alongside me for the Latin America cohort, we had Dr. Ishmael Hoare, who's an associate professor in the College of Public Health at the University of South Florida. And working alongside him is Villarmina Ponce Lucero, who's a social marketer from Peru and has a long history of working as a social marketer in the region. And so they were guiding the Latin America cohorts while I was working with the Caribbean cohort. Next slide. So the way the program is set up is 5 courses, and each course has around 4 to 8 lessons within it. And the lessons are quite interactive. It's not information at you. We provide information, provide practice examples, and then you apply it to a topic that you're working on. So the goal is for you not to just get information, but to get your hands dirty and to get experience on it. The very first course, Course 1, Social Marketing for Public Health, it just provides an overview of what is social marketing and shows social marketing in action on various health topics. So breastfeeding, heart disease, tobacco use, other topics of that sort, but it just shows success stories of social marketing in action. Following this initial course, which all the teams did on their own, then we moved into course 2 to 5, which focused more on the different planning stages. And so you see here that from July to December of last year, we had courses focusing on the planning component of it, and then planning for the research element. And then we took a break where the countries went out and they collected data, and they analyzed the data, and they understood what the insights were. And then we met once again between January and June of this year, where we used the data to inform the social marketing plan or the communication-based strategies, along with the monitoring and evaluation plan. And you will see that the presentations that they will share today are structured in this manner. Next slide. So just to give you a kind of an overview, you do not need to focus on reading everything that is presented here, but I just wanted to show you the level of commitment and work that took place. So from Latin America, we had around 8 teams from the region, 8 countries participating. And at times we had multiple teams within a country working on different topics. And so the topics that the teams were tackling included obesity on different elements of it, HPV, hypertension, and alcohol consumption. And as you'll see, the audiences were quite different. The audiences ranged from working with elementary school age children to adolescents, to parents of those children, to even Ministry of Health officials and staff, so employees in a work-based setting. So that was for Latin America. The next slide. This is just an illustration of some of the activities that they accomplished, just to show you the type of work that they generated. What you're seeing here primarily is one of the activities that they do early in the course, which helps them to go about selecting the behavioral focus. And so these are the return on investment charts that the country teams developed as a way to select what is our behavioral focus going to be, that will then in turn drive the selection of the audience that they're going to be working with. And so this is an example from Puerto Rico and then one from Panama, and you'll hear more about the Panama one later today. Next slide. For the Caribbean region, we had around 7 countries working on there as well. And again, the topics were related to hypertension, obesity, and alcohol use. And the audiences that we had here were working women and parents and children, as well as similarly employees. Next slide. So this is again showing you just an illustration. This is not at the planning phase, but more later on, once they had developed their communication strategies and had developed concepts for some of the countries. So here's Bahamas, Suriname, and Trinidad and Tobago, and how they translated their research into communication-based concepts. And then these concepts were in turn tested with their target audience prior to rollout with community-based activities. Next slide. So overall, we had around 80 hours of course engagement with our various country teams. So it was really a lot of time and effort was committed. The country team submitted around 15 different assignments or learning activities as part of the course. We had over 6 months over which we had weekly office hours. So we met with the country teams in the Latin America and the Caribbean cohort. And sometimes these office hours were once a week or multiple times as needed by the country members. So we had over 20 one-on-one country cohort meetings with tutors. Over 15 course-specific resources were sent to the individuals as well. The interesting thing to note in terms of what is the outcome or the product, we had 14 social marketing strategy formation workbooks that were created. And so in creating these workbooks and then down the line developing a communication strategy, keep in mind that 14 countries engaged in research in their countries with the target audience, synthesize that research and then use that research to develop a social marketing strategy. So we had around 14 countries do that at the end. And then at the end, around 17 people from the Caribbean region and around 12 from Latin America received certificates of completion for going through the entire course and then all working alongside us. So next slide. So one of the interesting things that we had this time is that we wanted to move the countries through these courses in planning for a social marketing intervention. But this time around, we wanted to move beyond just planning and also to support some of our country partners in the implementation component of it. And so for the implementation, we had some funding that was, again, generously provided by the American Heart Foundation and Association and their work. And so we were able to support Aruba and St. Martin, as well as Puerto Rico. You will hear from Aruba and St. Martin today. Puerto Rico, their work is still in the planning phases. Next slide. So these countries were provided the funding to provide support for the implementation. And as part of this work, USF, or the University of South Florida, and our collaborating center continued to provide technical assistance to support the countries as they went about developing, implementing, and evaluating their interventions in the field. And the panel discussion will showcase this work that has been ongoing for the last couple of weeks or months that we've been working with the teams. So next slide. So before I pass on the information to the country teams for them to share information with you, I wanted to share some of the lessons learned that we've had from our implementation. And this is lessons learned from the perspective of implementing this course and what we gained. One of the things that we found is that we had to add time and effort to the formative research. For the core, formative research is the listening and the research element of it, because we wanted to make sure that the countries didn't just receive information from the virtual platform, but they actually went into the field and applied what they learned to gain an understanding of how important formative research is to the social marketing process. And so that was an important lesson learned that we did, and we incorporated it into the timeline. In the future, we are also recommending that we put more time to accommodate for this research in the field. And one of the other interesting things, and you will hear it from our panelists, is that the panelists added this activity on top of their other activities that they were doing as their full-time job. And so they had to really balance the commitments required for this course along with their work. And so one thing we emphasized to PAHO, but then also to other countries, is the element of that if other staff want to go through this course in a similar manner, that there will need to be more time dedicated to it and more time given by the supervisor for them to be able to benefit truly from what the course is intended to accomplish. Next slide. So the next, what you're going to do is you're going to hear from the panelists about their experiences. But one thing I wanted to share with you, and we will be disseminating this later in the year, is that we're taking the lessons learned, the case examples from our implementation, and we're developing a social marketing toolkit or manual that is focusing on SALT reduction. And this toolkit and manual is currently in the development phase because we're using the case examples from the country teams that are going to be presenting to you as illustrations of the social marketing process and what they were able to accomplish, what they were able to learn. And we want this tool to serve as a way to not only guide other country teams and public health professionals on how to use social marketing, but then also to learn from the experiences of other teams in understanding that you may need to account for this, or you may need to do this, or you may need to adapt it in this manner to fit the context in which you're working. And so this manual should be complete by the end of this year, and then we will likely have another webinar or some activity as a way to disseminate this and share the information with you and others who are on this call. Next slide. So I've shared my contact information with you here. We have a question and answer area as well. So if any questions come up related to my presentation, please post it there. But then any other questions that will come up for the panel discussion, please post the questions in the Q&A and we will come back to them during the Q&A part. So now I'm going to move this back to Leo so that he can go about introducing the panelists so that they can share their experiences of implementing this program at the country level. Leo?
Yeah, thank you very much, Mahmouda, for this comprehensive overview of the program. And as Mahmouda said, any questions, please use the Q&A button, preguntas y respuestas, and we will be answering the questions in this QIA button. So just to emphasize as well that although in this course we have been emphasizing risk factors for non-communicable diseases, this social marketing planning approach is applicable to any public health topic. So what you will learn in this course is really how to do the planning from formulation to the problem until monitoring and evaluation and passing all the stages of the process, which will provide a more high quality campaign and more impactful. And we have shared the links of the course on in the chat as well. So please, if you're interested, you can do the course and you will get a certificate and you can disseminate the course as well among your contacts. So let's move on now to the panel. I'm going to switch to Spanish. Vamos a escuchar ahora unas experiencias de los países que han trabajado sus proyectos en la modalidad tutorizada. Y primero vamos a escuchar a una presentación de Aruba y de Saint Martin. Ellos son Dariana Everts y Sana van Kampen. Nos van a hablar de la reducción del consumo de sal para mujeres trabajadoras de hoteles en esas islas. Y tenemos también luego una presentación del licenciado Samuel Escudero del Ministerio de Salud de Panamá. Él nos va a hablar de la disminución de la ingesta de sal sodio en personal del Ministerio de Salud. Y enseguida tenemos una presentación sobre la disminución del consumo de bebidas azucaradas en escuelas con adolescentes de 12 a 17 años a cargo de la nutricionista Carol Madrid Morales de la Dirección de Investigación y Tecnologías en Salud de Costa Rica. Bueno, entonces cada panelista tendrá 10 minutos y luego tenemos un espacio de discusión y bueno, como ya dije, pueden poner sus preguntas en el Q y A y paso la palabra a las colegas de Aruba y de Saint Martin. Adelante.
Good morning, all. Thank you for the opportunity and allowing us to present our social marketing project. As previously mentioned, my name is Dahariana Averts, and together with my colleagues Ebrina Kurat, Iraida Tyson, and Participator, we're presenting this as a collaboration between the Ministries of Health and Ministry of Sport of Aruba. Next slide. Yes. Our goal is to assist in awareness and education to the community to consume less salt. Therefore, social marketing was the perfect tool for us to use in order to accomplish this. During our health campaigns, in which we provide free health checks in Aruba, we educate as well for the working demographic. We have analyzed that both men and women are not fully aware that their daily meal choices are not healthy. Next slide. So in discussion, we've realized that their perception of health is purely based on conversation, guessing. So that means that they haven't sought advice from healthcare professionals in order to be educated or receive full awareness of what they are doing. So their choices may cause diseases such as high blood pressure or NCDs, other NCDs, and this is both partial for the men and women in high percentages. Next slide. So what is the issue and what does this actually mean? That they are being made are based on convenience. So a lot of their choices is convenient. A lot of them is based on what is accessible to them. And the processed food is one that is of their many choices. It's a lot of salt consuming and a lot of sodium. And we know that salt consumption is known to be one of the big risk factors in developing the high blood pressure. And this results in the lower quality of life here in Aruba, the work performances, and consequently, a higher health cost for the people that are absent at work. Therefore, our ministries consistently collaborate together and educating the community of Aruba and using social marketing as our health promotion tool in creating a better quality of health and adapting positive social environments for all of their local inhabitants. Next slide. It is important to mention that we are currently working on guidelines regarding the salt consumption. While there is policy regarding the NCDs, but therefore, there's the initiatives with this social marketing tool, and the campaign is to bring the necessary impact and consequently develop policies on this subject. For our segment audience, we broke it down in 3 aspects. The primary is the working women within the Hilton resorts between the ages of 35 and 45, full-time or part-time working. The secondary, which will be the one they are impacting, which is their families, their co-workers, and other working women outside of the Hilton resort. And the third part is the collaborative hotels and the management team that are once responsible for the part of nutrition, food and beverages that is consumed on their practice and on their work. It's important to note as well that the campaign will not only be used at now, but we're going to be continuously using it throughout the year in other campaigns as well. So, as previously mentioned, the goal is to increase the awareness and promote salt reduction measures for the health benefits with multiple outcomes. For example, the understanding how much salt should be consumed for a better quality of health, understanding how to read labels, and as well as understanding how alternative ingredients such as spices and herbs can be used instead of salt. One of the analyses that we did, we can go to the next slide. Yes, is that the specific themes were highlighted in the analysis. 10 themes in total, but we just want to focus on 2 today, which life is tough. So good healthy food is expensive and takes too long for the preparation. So they tend to shortcut using canned or processed food, as I mentioned before. And as well as cooking for and with family when they cook, they also think about the traditional recipes that they use and the ingredients and traditional methods of cooking as well. So which means is our branding, product, and design needed to be something that's inclusive toward their family life, making the healthy choice the easiest choice for them, and connecting their healthy choices with a traditional meat, which for them was very important. So we shared on some of our examples. You can go to the next slide. You can see the colors based on our pre-testing phase. The colors were chosen by the working women. They want something that was not just gender neutral, but something that can be mixed. Their logo design was their choice. They wanted to see familiar faces. They wanted to see a professional. They wanted to see the meal and something to connect on their emotion. As well, they said that one of the branding aspect is the logo. They want to be able to recognize it in a very powerful logo and the signature that was going to be used as well. Next slide. There is a video on this. We can show a few seconds of it.
It says access is needed. Is it on a Google Drive?
Yes, then we're going to share this area. I hope for the PowerPoints to be able to be shared amongst the other colleagues as well. If we go to the next slide. Yes. Lastly, our monitoring and evaluation of this project is still ongoing. At first, we have 3 interventions. The first one will be from the data collection that was done in the pre-survey before our branding design was completed, understanding the knowledge, the highlights, and the themes that were present. The second and the third intervention, that's the moment that we're going to be really implementing our branding design, our campaigns, and all of the information that we've gathered. That will be used for awareness, education, and starting in this coming week, actually. And this will be done through social media, TV, radio. So we're going to be doing a media tour. We have a health expo on the 23rd of September here in Aruba as well. And that's going to be accessible for the whole community. And what we will do is do a post survey as well in the month of February of next year in order to see if the information that was provided to them brought clarity as in what salt consumption means, what sodium levels are, and how to read specific labeling and making, if indeed they made changes into their lifestyles to have a healthier lifestyle as well. And the third intervention, as you can see here, is to provide alternatives to the audience and the working women by working with the managers. That means all of the information that we are going to be providing is going to be provided to their managers, to the food and beverage distributors as well, in order to provide different variety and access to multiple products and substitutes for the community as well. Next slide. Our learning outcomes from the social marketing course, this is something very important, is what we've learned is to recognize the benefit of social marketing as health promotion tool for the public health. And this is the knowledge that we've shared not only with the public health ministry, but also with the sport and the social. We've created programs that are positive for the behavioral changes, where we highlighted the benefits and especially showcasing the positive behavior outweighs the negative. Very important to increase the knowledge and the methods to make it the healthier choice, the easiest choice, providing them with the resources that are accessible for the community in total. As well, the creating of the communication plan. This was indeed for us very specific because we had to design and adapt according to what the audience wanted as well, and the plan of using the specific data that we received along the way to target our segmentation and customize our programs. And lastly, the understanding of the branding and the implementation and the impact that it has throughout the process, and how this can be best monitored and evaluated in order to be used as a tool for other campaigns as well. Next slide. That's a little bit for us. Our campaign is called Más Salud, Menos Salo, cu sabor de casa, which means more health, less salt with flavor of home. So on behalf of the One Happy Island here in Aruba, we want to say thank you, and gracias for your attention.
Dankjewel, muchas gracias. Thank you very much. So we continue now with the panel with the next presentation. And this presentation will be done by el licenciado Samuel Escudero del Ministerio de Salud de Panamá. Él nos va a hablar de la disminución de la ingesta de sal sodio en el personal de salud del Ministerio de Salud de Panamá. Adelante.
Leo, perdón. First, we have the presentation from Saint Martin.
Sorry. Okay, adelante. Then we listen first to Saint Martin.
Okay, Thank you very much, Leo. I hope my camera is working. I'm not sure about it.
Yes, we can see it.
Okay, yeah, I can't see myself, but okay, it's working great. Thank you very much. I'm Sanne van Kampen. I'm the advisor on non-communicable diseases of the Ministry of Health in Sint Maarten. And I'm now going to share with you our experiences with following the social marketing course and developing public health and social behavioral change campaign for reducing salt consumption. Next slide, please. So first, a little bit of background on Sint Maarten. Sint Maarten is a very small country in the Caribbean. Data from 2015 shows that 32% of adults self-reported to have a high blood pressure. So that's rather high. We realize salt consumption is an important contributor to hypertension. And although the government of Sint Maarten regularly implements public health awareness campaigns around healthy eating, we haven't had one that specifically focused on salt reduction. And we haven't had one that used social marketing techniques to develop such a campaign. Next slide, please. So in the course, we worked very closely with Aruba, and we adopted the same focus and population target for our campaign. So our aim was to reduce salt consumption and use among working women between the ages of 35 and 45, employed at large hotels. And this group was specifically chosen, first of all, because there was preliminary data available amongst this group about their healthy, their behavior with regard to healthy eating. So we had a little bit of insight into this group already from Aruba, and also it was realized that this group is has limited resources in terms of income and time, usually, to eat healthily, and also they are important stakeholders in. They are usually, you know, the primary caretakers of their families. So changing their behavior would impact on their families as well as the community as a whole. So introducing our team, there's myself, and I work at the more policy department of the Ministry of Health. And we have our colleagues, Ivanka Sterling and Swinda Richardson, who are working in the health promotion team of the ministry. And we work together with the University of Sint Maarten, and Raymond Jesseroen is the researcher from that university that helped with the formative research. Next slide, please. So for our part of the formative research, we interviewed 14 women working in Oyster Bay Beach Resort, one of the 4 large hotels in Sint Maarten. And we assessed their knowledge, perceptions, and behaviors with regards to home meal preparation, shopping, as well as, you know, takeout food. And basically, the results show the following main findings or actionable insights. So we realized from talking to these women that they're not exactly aware of how much salt is consumed, mostly because salt is hidden, is part of other products that they consume. And yes, it's hard, you know, they don't have usually a lot of time to read labels in the supermarket. So the other finding was that they don't usually use a lot of fresh seasoning or herbs to season their meals, but rather pre-packaged spice mixes, for example. Also, to save time, meat and other products are often defrosted using salt. Also, most women consider frozen vegetables not as healthy as fresh vegetables. Since fresh vegetables are very expensive, they often opt for canned vegetables and other products, which then often contain salt as well. And finally, most women have not a lot of time to cook at home, so 2 out of 3 meals come from the workplace. Next slide, please. So, Sint Maarten, again, in collaboration with Aruba, developed a communication plan for the social marketing campaign. And our main message was less salt, more health. So it is an English-speaking country, St. Martin, in principle. We do have a lot of Spanish and Creole speakers as well, not a lot, but some. So we will be translating our messages into those languages as well. And what we realized was that we had to focus on, what motivates these working women, what are their barriers. So we found that for them, it's very important to feed their families and keep them healthy. That's basically their main concern. So they were open to learn new ways of cooking, but they wanted to keep with tradition and with traditional flavors. And the way they get information is usually through family, friends, and social media. Their main barriers to healthy eating are limited access to fresh food due to the very high prices of vegetables and fruits, for example, a limited time to cook healthily, and they are reliant on old habits, again, due to time, mostly with regards to shopping and seasoning. So we said, okay, our main aim should be to change behavior, and to change their behavior is for them to teach them how to choose alternative food products or cooking techniques with less salt that are healthier, but do not cost money. Next slide, please. So we developed 3 activities. The first one is we're going to do cooking workshops for the female hotel staff in all 4 large hotels. So NIPA, that is the National Institute for Professional Advancement. They have chef instructors. They have worked out a curriculum for these cooking workshops, and we'll perform 2 workshops in October, November this year. And we're going to assess the outcomes of these cooking workshops by doing questionnaires before and 3 months after the workshops, assessing their knowledge, perceptions, and behavior regarding salt use of the participants. The second activity is that we have, together with a graphic designer, designed signs to be placed in supermarkets. We call them wobblers, that try to convince or motivate people to reduce consumption and procurement of high salt products. So we'll place them in the aisles with high salt products, as well as the alternative products. We'll display those wobblers in four supermarkets over the course of 4 months this year. And we're gonna try to evaluate the decrease in supermarket sales of high salt products from now until the third activity is we're going to advertise on social media, especially on the government Facebook pages, using messages that have been designed by the graphic designer again, that are similar to the wobblers in the supermarket. And we're going to evaluate the estimated number of social views on the Facebook page to evaluate that activity. Next slide, please. So this is the first draft, let's say, of the graphic design of the wobblers. And the social media ads will look similar. And yeah, we didn't have the capacity to pre-test these among the target population, but with input from Muda's team, we've had very good advice on how to adjust this and finalize these images. But it will, the graphic, yeah, they will look like this, but we're tweaking still a little bit the text and the image. Okay, next slide. The cooking workshops, yes, we have held similar cooking workshops in the past with NIPA, and we're going to do the same later on this year, but then with specific focus on, alternative cooking products and techniques to reduce salt. Final slide, please. So basically, we're finalizing, as next steps, we're finalizing the designs of the social media ads and supermarket signs. And we're finalizing the cooking workshops curricula. And then the lessons learned for us from following the course and developing the social marketing campaign was, first of all, we realized that we shouldn't focus really on the barriers that people are facing to healthy eating, but more so even maybe on motivators. What motivates them to change their behavior? Because they are willing to change behavior, at least our target population was, but we had to find out what really would motivate them to do so. And secondly, we realized how much time it took and how much meetings to sit with the graphic designer to create the designs, the creative concepts for this campaign. So that really is a lesson learned for future campaigns as well. That the researchers and the graphic designers have to sit together many times to go over these concepts. And then finally, we now realize the importance of monitoring and evaluating the campaign. Something that we haven't done before, but it's of course gonna give a lot of information for us on the success of the campaign going forward. So with that, I want to thank you and looking forward to the questions from the audience. Thank you.
Thank you very much, Sanne, for this interesting experience. I see there are already a few questions in the chat. Maybe you would like to answer them in the chat. And after the panel, we will have a discussion. But let's now listen to Panamá. Tenemos con nosotros el licenciado Samuel Escudero del Ministerio de Salud y nos va a hablar de la reducción del consumo de sal sodio en Panamá.
Buenos días.
La palabra.
Buenos días a todos y todas. Gracias por esta oportunidad. Bueno, lamentablemente la compañera que trabajó conmigo toda esta estrategia está, bueno, no lamentable, está de licencia por maternidad, así que no nos va a poder acompañar en el día de hoy. La siguiente, por favor. La compañera es la licenciada Arelis Aguilar, ella es nutricionista y estuvo con nosotros durante todo el proceso. La que sigue. Un poco viendo los antecedentes, en el año 2019 se hizo un estudio sobre los efectos del consumo de sal y sodio en Panamá y entre los resultados principales que este estudio pudo aportar estaban las enfermedades cardiovasculares principalmente causadas por hipertensión arterial relacionadas al consumo de sal y de productos con alto contenido de sodio. El 77% de las muertes que fueron relacionadas a la GNT y de esas el 30% específicamente a condiciones cardiovasculares. La hipertensión fue del 43.3% de los adultos que fueron encuestados y el 27.8% siempre manifestó que agregaba sal a las comidas antes de comer o mientras comían. Y el 45.1% de la población mayor de 15 años consumía semanalmente alimentos altos en sodio. Entre las intervenciones que se pudieron lograr después de esta encuesta de salud, fue la implementación del Plan Estratégico Nacional para la Prevención y Control Integral de las Enfermedades no transmisibles y sus factores de riesgo, que está vigente hasta el 2024. La resolución 049 del Ministerio de Salud que estableció la eliminación de los restaurantes de la sal colocada en mesas y el plan de acción de reducción de consumo de sal sodio y la eliminación de las grasas trans que fue presentado el año pasado con el apoyo de la OPS, que es del 2022 al 2025. La que sigue. Después de ver todo este panorama y que pudimos determinar también que los adultos que consumían alimentos con alto contenido de sal y sodio eran los que más tenían problemas con la hipertensión, y más esos factores agravantes como una falta de política nacional de la reducción de sal y sodio que hasta este momento afectaba. Estamos ahorita mismo, el país está en lo que es la discusión del etiquetado frontal para los alimentos con altos contenidos en sal y sodio y también con los alimentos que tengan altos contenidos de grasas trans y grasas saturadas. Eso todavía está en proceso, está todavía en discusión. Y también tenemos que tomar como factores agravantes la exposición continua de los medios de comunicación que hablan ampliamente de sus productos y que sabemos que tienen altos contenidos de sal y sodio. Una de las, diríamos que, desventajas de ser un país multicultural como es Panamá es que vino mucha gente trayendo sus formas de cocinar, sus costumbres en el uso de condimentos. Y por ejemplo, podemos ver que de la región de Asia se utilizan muchos condimentos que a la larga tienen un potencial efecto sobre la salud, y eso nos ha traído como consecuencia que tengamos estas situaciones en la costumbre de alimentarse del panameño, que entre más sal o más condimentos para mucha de la gente en Panamá es lo mejor, o sea, es la comida más sabrosa y la que la gente prefiere. La que sigue, por favor. Ya entrando específicamente en los resultados que nos sirvieron para establecer las estrategias, estaba en el uso de condimentos naturales para reducir el consumo de sal. Se puede observar los tiempos de comida, también que es medible, o sea, cuántas veces se preparan los alimentos en casa. Es realizable en el momento de preparar los alimentos en casa, o sea, aquí tratamos de que las personas que iban a participar con nosotros en esta iniciativa pudieran reducir el uso de sal durante la preparación de los alimentos, y la práctica de que se pueda hacer en casa, preferiblemente traer los alimentos de casa y no comprar alimentos ya preparados en el área de trabajo. Y el tiempo que sería diariamente. La que sí. Los principales resultados que pudimos encontrar en la encuesta que se realizó a las compañeras, se hizo una encuesta en línea en la plataforma de Google Form, donde cada una de las compañeras participó, llenó, y los resultados, ahí pudimos observar los obstáculos percibidos, los comportamientos opuestos, los beneficios percibidos y los factores de motivación, las personas que influyen en las decisiones, los lugares que influyen y los medios de divulgación. También se hicieron 3 entrevistas a profundidad y se hizo un grupo focal también con las compañeras para obtener la mayor cantidad de datos posible para la elaboración entonces de la estrategia como tal. La que sigue. En la comparación de la estrategia entre los obstáculos que pudimos encontrar y cómo lograr mejorar esos obstáculos encontrados, entre ellos está sembrar y organizar huertas en casa. ¿Por qué las huertas en casa? Porque tener alimentos, o sea, condimentos frescos que son sencillos de tener. Por ejemplo, en Panamá se usa mucho una hojita que se llama culantro acá, que sirve mucho para aromatizar y saborizar alimentos. Y es de fácil, se siembra con facilidad y no requiere muchos cuidados ni cuidados especializados. El otro que se le manifestó a las compañeras es que estos condimentos se pueden licuar y pueden ser guardados en el congelador en forma de cubos de hielo para luego ser usados posteriormente. Porque si se dejan directamente en la nevera sin procesar, sabemos que se corre el riesgo de que no duren mucho tiempo y que se deterioren. También se habló de la planificación de las compras previamente, o sea, hacer listados previos de cuáles son los condimentos que se van a utilizar en casa, tomando en cuenta que deben ser frescos y naturales. Planificar la preparación, utilizan condimentos porque no todas las preparaciones llevan condimentación. Planificar la preparación y la utilización de condimentos naturales, cambiar el uso de sal artificial por forma de alimentación y conservación de los condimentos naturales, como ya le mencionaba anteriormente, de congelarlos, aprender y hacer y a utilizar caldos naturales, eso también para eliminar el uso de estos calditos concentrados, que como sabemos tienen alto contenido de sal, sodio y de grasas saturadas. Cambiar la forma de cocinar los alimentos, llevar al trabajo comidas saludables hechas en casa y la promoción de un kiosco saludable en el lugar de trabajo. Esa es una de, de, de los elementos que quedaron manifestados en la encuesta que se hizo, de que muchos de las compañeras decían, bueno, ¿y por qué el Ministerio de Salud no cuenta con un restaurante donde se puedan adquirir alimentos saludables? Y fue bien interesante, y de ahí podemos establecer otra estrategia para entonces presentarle a las autoridades del ministerio esta posibilidad. La que sigue. Bien, en los procesos de planificación e iniciativa, pudimos ver primero la audiencia secundaria, que incluyó a los familiares de las compañeras, porque ya sabemos que la audiencia primaria son nuestras compañeras de trabajo entre 20 y 50 años, y los influyentes, que son los profesionales de salud que pueden hablar a favor de lo que queremos hacer. La promesa clave: si yo disminuyo el consumo de sal utilizando condimentos naturales, voy a prevenir enfermedades como la hipertensión y del corazón. A la vez será una manera saludable de complacer mis gustos y el de mis familiares. El tono es lindo y sabroso: preparar y consumir en familia alimentos naturales y con menos sal. Y la declaración de apoyo, porque al utilizar condimentos artificiales aumenta mi consumo de sal, sodio y las preparaciones en el hogar. Y la meta que nos establecimos fue aumentar el uso diario de condimentos naturales para darle sabor y color a las comidas preparadas en casa en cada tiempo de comida, en lugar de los condimentos artificiales. La que sigue. Bien, el proceso de planificación, el concepto creativo, utilizamos un eslogan que se llama: con lo natural, dale color y sabor a tus comidas. Va a haber un video con información sobre el uso de plantas para condimentar. Ya tenemos un recetario en una primera versión que contiene recetas bajas en sal y sodio y con condimentos naturales. También se tiene un recordatorio que es en forma de un cucharón de madera, que es muy utilizado en nuestro país, sobre todo en las regiones eh, rurales del país, y que tiene un mensaje: el mensaje que con lo natural dale sabor y color a tus comidas. Esto es como para tenerlo en la cocina, en el área de preparación de los alimentos, y que sirva de recordatorio a la persona cuando va a preparar los mismos. También ya tenemos unos stands que se están utilizando en las ferias que hacemos a nivel del mismo Ministerio de Salud, con información de la preparación de los alimentos y también con información tipo volante, brochure, etcétera, sobre los riesgos del consumo de sal y sodio excesivo. Y lo último sería la colección de plantitas, que las personas que participaron con nosotros se le van a estar entregando posteriormente unas macetas pequeñas con algunos condimentos que pueden ir teniendo en casa, y que son de fácil cuidado y que no requieren mucha atención. La que sigue. Bueno, esto de los próximos pasos nos habían dicho que era para el final, pero bueno, está el lanzamiento de la estrategia de comunicación, el desarrollo de los talleres con las funcionarias sobre la estrategia de comunicación, distribución de materiales de comunicación, desarrollo de la colección de plantas de condimentos naturales, presentación en el stand sobre condimentos naturales y difusión de videos. Y la que sigue. Durante el proceso, la utilización del mercado, o sea, pudimos, dentro de las lecciones aprendidas y que nos quedó a los dos que participamos por parte de la Dirección de Promoción en esta capacitación, fue que la utilización del mercadeo social puede implementar de manera coherente las estrategias para lograr cambios positivos en los comportamientos de los individuos. Mediante el mercadeo social, las intervenciones en salud irán dirigidas a los públicos prioritarios con mensajes claros y precisos, y el costo-beneficio de las intervenciones serán más eficientes, y el desperdicio de recursos se resume significativamente. La metodología de análisis del mercadeo social es adecuada para lograr cambios efectivos y sostenibles en el tiempo, y el mercadeo social garantiza intervenciones más costo efectivas y adecuadas. La que sigue. Y ya con esta imagen de la ciudad de Panamá de noche cerramos entonces nuestra presentación.
Muchas gracias y muy interesante también esa experiencia. Ya hay algunas preguntas para que las responda por favor en el chat. Y vamos a nuestra última presentación de este panel, que es una presentación de Costa Rica de Carol Madrid Morales sobre el consumo de bebidas azucaradas en escuelas. Adelante.
Buenos días, es un placer estar acompañándolos esta mañana. Voy a dar inicio a la presentación, que es una propuesta de plan estratégico de mercado social para la reducción del consumo de bebidas azucaradas preenvasadas en la población adolescente de Costa Rica, elaborada desde el equipo conformado por Adriana Bolaños Cruz, José Cambronero Miranda y mi persona, todos del Ministerio de Salud. Adelante. Antecedentes y problema de salud. Como se muestra en el gráfico número 1, la población adolescente costarricense tiene una tendencia ascendente de la prevalencia de sobrepeso y obesidad. Según la encuesta nacional de nutrición en el 2009 era de 20.8% y ya en la encuesta colegial de nutrición del 2018 alcanzó a 30.9%. Estudios en Costa Rica han demostrado que los adolescentes consumen en promedio 75 gramos por día de azúcares añadidos, en este caso superando las recomendaciones de la Organización Mundial de la Salud del 10%. Y la principal fuente de azúcares añadidos fueron las bebidas gaseosas en alrededor de un 24%. Además, la frecuencia de consumo de estas bebidas de 2 a 6 veces a la semana alcanza un 33%. Adelante. En este sentido, preocupa la ingesta elevada de azúcares libres, especialmente en forma de bebidas azucaradas, dado que puede aumentar la ingesta de calorías por un lado y por otro disminuir la ingesta de calorías proveniente de alimentos con un buen perfil nutricional. Esto puede causar una dieta malsana por su adecuado balance nutricional, un aumento de peso y un aumento del riesgo de desarrollar enfermedades no transmisibles, las cuales se les ha atribuido la alta carga de morbi-mortalidad, altos costos de atención en salud y generación de grandes pérdidas económicas en el país. Adelante. Para dar respuesta a esta situación, contamos con la Estrategia Nacional de Abordaje Integral de las Enfermedades No Transmisibles y Obesidad, conocida como Estrategia ENTO, y su plan de acción, y las nuevas guías alimentarias basadas en sistemas alimentarios dirigidos a la población adolescente, donde tiene mensajes específicos que promueven la disminución de las bebidas azucaradas. Adelante. El propósito del plan de mercadeo que estamos proponiendo es el siguiente: contribuir a la disminución del consumo de bebidas azucaradas preenvasadas para la prevención y tratamiento de la obesidad en la población adolescente, según la meta establecida en la estrategia ENTO. Adelante. La población meta, audiencia principal, los adolescentes con un rango de edad de 12 a 17 años, audiencia secundaria, padres de familia, profesores del centro educativo y el personal que trabaja en las SODA de los colegios. Adelante. Los resultados de la investigación formativa. Las barreras que reportaron los adolescentes en relación a la disminución del consumo de bebidas azucaradas son las siguientes: la adicción que genera, la falta de voluntad que ellos perciben que tienen, el entorno alimentario del hogar, dado que los padres de familia son los que compran estas bebidas en sus casas, el buen sabor de ellas y por otro lado el feo sabor del agua y la saciedad que generan. Y las barreras que reportaron los adolescentes con relación a la preferencia del consumo de agua son el poco refrescante que es el agua no tiene sabor, no tener una botella de agua, la poca accesibilidad al agua, la dificultad de generar el hábito del consumo del agua y la temperatura de ella. Siguiente. Y los motivadores o beneficios que los adolescentes reportaron con mayor frecuencia con respecto al consumo de bebidas azucaradas envasadas fueron el gusto, placer, seguido de economía, conveniencia y popularidad. Y con relación a la disminución del consumo de bebidas azucaradas y la preferencia del consumo del agua, fueron la salud para tener mejor nutrición y mejor rendimiento físico. La revisión de literatura también nos indicó que los adolescentes valoran la protección del medio ambiente por tener una mayor conciencia ambiental. Siguiente. A partir de los resultados de la investigación formativa, generamos los conceptos creativos considerando los aspectos que valoran los adolescentes en relación a salud, nutrición, protección del medio ambiente, sabor, gusto, frescura, placer, rendimiento físico. Y definimos como propuesta de valor lo natural, por su asociación con lo puro, por no estar intervenido por el ser humano con ningún procesamiento industrial y que nos brinda salud. Además, nos permite hacer vinculaciones con las distintas ideas de los conceptos creativos y generar una relación convincente que pueda influir o motivar a los adolescentes a llevar a cabo el comportamiento deseado. En este caso, disminuir el consumo de bebidas azucaradas preenvasadas y preferir el consumo de agua como un comportamiento alternativo o sustituto. A partir de estos análisis se identificaron y se desarrollaron distintos eslogans, los cuales van a ser estas ideas que van a motivar a esta población, tales como: por mi salud y protección del medio ambiente, reduzco el consumo de bebidas azucaradas envasadas. Tomo agua por mi salud y protección del ambiente. Hidratarse en forma natural y sin azúcar es más sano. Tome agua, es natural y saludable. Es muy importante validar estos eslogans con el público meta antes de ser divulgados. Adelante. Se definieron objetivos y metas en el ámbito de conocimiento, creencias, comportamiento, por lo cual se espera persuadir a los adolescentes y posicionar el valor que es disminuir el consumo de bebidas azucaradas en la población adolescente. Algunos ejemplos de objetivos de comportamiento son: disminuir el consumo de bebidas azucaradas preenvasadas, preferir el consumo de agua en lugar de estas bebidas azucaradas, saborizar el agua usando vegetales y frutas de temporada, cargar siempre una botella reusable para el agua, influir en la decisión de los padres de disminuir la compra de estas bebidas azucaradas en el hogar y usar las etiquetas nutricionales para seleccionar las bebidas con menor contenido de azúcar. Adelante. Seguidamente se elaboró la mezcla de mercadeo que tiene como objetivo persuadir a los adolescentes para llevar a cabo este comportamiento deseado considerando las 4 P. Adelante. En la estrategia de producto se identificó el producto real, que sería disminuir el consumo de las bebidas azucaradas y preferir el consumo de agua. El producto principal, resaltando todos aquellos beneficios que puede percibir o recibir la población meta si lleva a cabo el comportamiento deseado, tales como tener una vida natural, fresca, con buena salud, mejorar la nutrición y el rendimiento físico. Y el producto aumentado son todos aquellos elementos que pueden facilitar y motivar a la población a llevar a cabo el comportamiento deseado, como proveerles botellas para uso exclusivo del agua, darles regalías como un álbum de stickers, tener acceso gratuito a una plataforma web interactiva o a un app donde puedan tener acceso a diferentes recursos educativos abiertos, videos, recetarios, folletos educativos. Siguiente. En la estrategia de precio, en un primer momento se identificaron todos aquellos costos o barreras que la población meta percibe si lleva a cabo el comportamiento deseado, como disminuir el consumo de agua. Y posteriormente se establecieron una serie de intervenciones o acciones que podemos llevar a cabo para poder enfrentar estas barreras. Por ejemplo, en el ámbito de preferencias alimentarias se identificó la barrera del poco sabor y frescura del agua. Entonces, se definió que se podrían desarrollar talleres de gastronomía o cocina para enseñarles a los adolescentes de cómo preparar agua saborizada, haciendo uso de vegetales, especias y frutas de temporada. En la estrategia de plaza se identificaron aquellos lugares donde la población meta puede llevar a cabo el comportamiento deseado. En este caso serían en la zona del centro educativo y en el hogar. Y se identificaron estrategias que se pueden implementar para poder generar los medios y las condiciones que facilita a la población meta llevar la disminución del consumo de bebidas azucaradas o aumentar el agua. Entonces, en el caso del hogar, si nosotros sabemos que una barrera es que ellos están expuestos a este ambiente del hogar, a las bebidas azucaradas porque los padres las compran, consideramos importante sensibilizar a los padres sobre los riesgos de consumo de las bebidas azucaradas y los beneficios de aumentar el consumo de agua. En esta estrategia también identificamos a aquellos intermediarios o actores sociales que también pueden participar en el desarrollo de las intervenciones, como es la Caja Costarricense del Seguro Social, la Cámara de la Industria de Alimentos, la Asociación Nacional de Chef, el Ministerio de Agricultura y Ganadería, entre otros. Adelante. En la estrategia de promoción se identificaron distintas actividades que podríamos desarrollar para poder divulgar nuestros mensajes. ¿Cómo es elaborar una campaña de comunicación sobre cómo disminuir el consumo de estas bebidas azucaradas, aumentar el consumo de agua, sus riesgos y beneficios? Además, promocionar retos mediante una plataforma web interactiva o en el app que permita a los adolescentes ir acumulando puntos y estos puedan intercambiarlos por botellas de agua, entradas al cine, descuentos de artículos deportivos, y también desarrollar campañas mediante giras en los centros educativos que tengan el nombre, por ejemplo, natural, de acuerdo a la propuesta de valor, y así poder realizar concursos de canciones, obras de teatro, rallies entre los adolescentes. Y también se identificaron los canales de información donde se puede divulgar los mensajes. Canales de comunicación donde se puedan divulgar los mensajes, como en las redes sociales, plataformas del sitio web o del app, los mensajes de texto, WhatsApp, correos electrónicos virales, y los portavoces pueden ser profesionales de salud, los mismos padres, los mismos jóvenes o artistas famosos o chefs famosos, todo esto dependiendo de la actividad promocional. Adelante. Las lecciones aprendidas, es muy importante definir este tipo de planes de mercadeo social de acuerdo a la evidencia y las mejores prácticas. En el caso de Costa Rica, nos basamos en la experiencia que tenemos previamente con un plan de mercadeo social para aumentar el consumo de frutas y vegetales en adolescentes, y también todo el trabajo que tenemos con relación a la disminución del consumo de sal y sodio, con este enfoque de mercadeo social. También hacer estos trabajos enfocándose a las personas, considerando todos estos valores, barreras y motivadores que ellos tienen para llevar a cabo el comportamiento, y así poder identificar qué acciones sustitutas les podemos dar y que se nos facilite los comportamientos que deseamos. Muy importante promover el trabajo multidisciplinario y multisectorial, no solamente para considerar todas las visiones, sino también para hacer uso efectivo de los recursos del Estado. En este curso, una de las grandes experiencias fue también poder conocer la realidad de los otros países y de las formas de trabajo que se tienen. Y importantísimo es tener siempre la viabilidad y el compromiso de las autoridades en este tema para continuar apoyándolo. Siguiente. Muchas gracias y ahí está mi contacto. Agradezco su atención.
Muchas gracias. Y nuevamente un tema muy interesante, pues obviamente el mercadeo social se puede aplicar a cualquier tema de salud pública como vemos acá, y cada tema necesita su propio análisis. Y sí, desafortunadamente en muchos países sí toca hacer una campaña, lo primero que se piensa a menudo es, bueno, que ponemos en el afiche o que ponemos en el folleto sin pasar por todo este proceso, ¿no? De la investigación formativa y de definir bien la problemática y los beneficios para el grupo objetivo. Entonces, este precisamente es el objetivo de este programa, de crear más capacidad para hacer este tipo de campañas de calidad, particularmente en los ministerios de salud. Nos quedan unos 10 minutos más para algunas preguntas y respuestas. Veo que ya hay muchas preguntas respondidas también en el chat. Yo quería hacer una pregunta a todos los panelistas, y eso consiste en, ahora que han llegado tan lejos con su diseño de campaña, ¿cuáles van a ser sus próximos pasos, digamos, y cuáles son los planes de implementar también estas campañas? Y escuchemos primero a las colegas de Saint Martin y de Aruba. Escuchemos a Dariana y a Sana, por favor.
So I can start. Yes.
You can start.
Thanks
Okay.
for that question. So in terms of implementation of this specific campaign, yes, we are moving forward with the 3 activities that we designed. So including social marketing, social media advertisements in markets, and cooking workshops. So those concrete elements will be implemented before the end of this year, all of them, and then we'll evaluate just where needed, and also think about taking this particular campaign forward and into the next years, and see how we can keep on adjusting and tweaking it. If we're talking about the whole concept of implementation of social marketing, behavioral change campaigns, I think the course has been very, very informative, and we intend to do this, practice this similar methodology more often in the future. So what I'm doing personally, because I was a participant in this course, is making some taking the teachings and lessons that I received into a shorter training package for the people in Sint Maarten. So that includes my colleagues from the government, and also we're thinking about including other stakeholders, just so that we can disseminate the teachings from this course within the country.
Thank you very much, and that sounds very good also to involve other colleagues. So that's great. Okay, then let's listen to the colleague from Aruba as well, Dariana.
Yes, for the continuing implementation, we would have to, it's nice that the social marketing as a tool was able to create a name for what we were doing already. Similarly, one thing that was very important, the monitoring evaluation aspect for us, which is still ongoing, it's something that it allowed us to really break down each aspect, connecting with the stakeholders that are relevant for us to implement it properly, and also doing the pre and post survey will really allow us to analyze as to what is the impact, how high is the impact, where can we create guidelines accordingly in order to connect it with policy that we would need to do it as well. And one aspect of the communication plan, as previously mentioned, it really created a specific design that was customized for our community and using the resources that we have. Because a lot of the times we depend on social media in order to bring information out there. But now we've realized that it's not only social media, we would have to bring the access and information as well in the field, which was bring it to the community within the hotel sector and other working environments that they're currently at.
Okay, thank you very much. Entonces hacemos la misma pregunta al colega de Panamá. ¿Cuáles son los pasos siguientes, digamos, de en realidad implementarlo? ¿Cuáles son ya los planes concretos? Y también diseminar lo aprendido con otros colegas en el país.
Bueno, perdón, la intención es una vez terminada el proceso en la dirección de promoción que fue, digamos, el piloto de la implementación, sería llevarlo entonces a los niveles regionales. El sistema de salud nuestro está dividido en 15 regiones de salud que abarcan todo el país, y las regiones de salud a su vez manejan las instalaciones de salud, en las cuales contamos con personal de promoción de la salud en cada una de esas regiones y de las instalaciones. Entonces, llevando esto nos va a permitir entonces poder llegarle a más personas desde el nivel nacional, al nivel regional y al nivel local. Y ya entonces en el nivel local sería la intervención directa ya con la misma comunidad como tal. Entonces, esa es la intención. Una vez terminado acá en el nivel nacional, ir bajando entonces a los otros niveles.
Entonces, igual nos gustaría escuchar de Costa Rica sus planes inmediatos.
Sí, muchas gracias. Sí, se ha conversado de la importancia de seguir capacitando en el tema a nivel de la institución, y también definir una estrategia de movilización de recursos para poder tener financiamiento y continuar con todo el proceso de implementación, monitoreo y evaluación del mismo. Pero por otro lado también queremos como ya aprovechar el trabajo que se ha hecho, entonces definitivamente sí se debe como de validar todos estos conceptos creativos y los eslogans que se definieron con el público meta, dado que es sumamente importante generar un material donde la población se sienta identificada y que sea comprensible para ellos, y a partir de ahí ya definir todo este plan de implementación que se requiere. Gracias.
Okay, muchas gracias. Then I hand over to Mahmouda. There's a question about public policies he would like to respond, and there's just another question coming in, which I think is also interesting. It's about how many people are typically needed in the field to successfully complete social marketing projects. So let's listen to Mahmouda.
Sorry, Leo, can you ask that again? I was just typing the question.
Yes, the question about the public policies, it's for the integration of the work, if
Yes,
the public policies are taken into account, and also how many people are typically needed in a unit or team in the field to successfully complete a social marketing project.
So I'll answer the first part, which is
Okay.
that, you know, there isn't necessarily a minimum, but I think it's always good for social marketing to have a couple of individuals working together, because if you're going to be engaging in the research component, and then also just to pull the work together. So I would say a minimum of 2 is starting point, or 3 people, and that should be sufficient. Regarding the integration of policies, that was a question that was very interesting that I saw, and I thought it would be a good question for some of our country teams to respond to, especially I believe with St. Martin and Costa Rica, because they addressed it in their presentation. So that question I wanted to actually send back to the country teams to see if they're able to respond to it in terms of how they're integrating their work into the larger policies that may exist within their countries.
Okay, let's then first listen to Aruba. How is this, how you integrate your campaign into the public policies of the country?
Yes, for the integration part, initially when we launched the campaign next week, it directly involves the Department of Public Health, which is under the Ministry of Health, and our collaboration within our team, we had also the Ministry of Sports. And the point will be like, when the implementation is starting of the campaign, we will be writing a report for our ministries and presenting it to them, because that's where the part of the policy can be created as well. And the adjustments that we do along the way will be with the policy advisors at the Department of Public Health, which is connected within the ministries. And we hope with that in the future to be able to create specific adjustments and guidelines that we can implement in Aruba as a whole when it comes to salt products, the labeling aspect of as well as what is given as nutritional products within the not only the hotel sectors, but available for working people in general.
Thank you very much. Escuchemos también a Costa Rica, cómo ellos integran su proyecto de mercadeo social en las políticas públicas.
Bueno, tal vez les voy a comentar un poco la experiencia con relación a las guías alimentarias dirigidas a la población adolescente, que es lo que ya se ha implementado un poco. Mi experiencia previa con el trabajo de mercado social en la reducción de sal y sodio sí me permitió aportar este conocimiento en las guías alimentarias, y fue más que todo a la hora de desarrollar los mensajes con los adolescentes, donde sí generamos todo un concepto de valor. A partir de ahí se definieron los mensajes y posteriormente se llevó a cabo el proceso de validación. Entonces ha sido un medio que hemos podido divulgar el tipo de estrategia de mercadeo social, y ha permitido también transmitir este tipo de aspectos que valoran los adolescentes a la hora de mantener una alimentación saludable. Y ya luego también hemos hecho todo un impulso desde el tema de reducción de sal y sodio, más que todo divulgando lo que es una propuesta de plan que existe ya a nivel nacional, y se ha hecho sensibilización, se ha elaborado un policy brief y también actividades científicas para poder hacer un poco de lobby a nivel de las autoridades y que ellos consideren estas estrategias de mercadeo social como una estrategia efectiva para posicionar la salud en la población y que estos comportamientos se mantengan a largo plazo. Como recalqué anteriormente, es muy importante continuar sensibilizando en el enfoque mercadeo social para dejar atrás todas esas estrategias tradicionales de comunicación, educación e información en la población y posicionar el mercadeo social como una estrategia, como un best buy que es, y que los gobiernos inviertan en el mercado social.
Muchas gracias. Entonces, vemos la importancia de que el mercadeo social no es una estrategia aislada, sino es un complemento a otras políticas y programas, también que no es únicamente para un cambio individual de comportamiento, sino también para un cambio social que también puede ser usado para abogar por políticas públicas. El programa sigue abierto. Hemos puesto en el chat el vínculo del programa de mercadeo social. Está disponible en el campus virtual de salud pública de la OPS, tanto en español como en inglés. Continuamos con la modalidad de autoaprendizaje. Hasta ahora 16,000 personas se han inscrito. Esperamos que luego de este taller ustedes también tienen el interés de hacer el curso y que ayuden a divulgarlo entre más profesionales. Por el momento no tenemos una modalidad tutorizada, pero en el futuro posiblemente volvemos a abrir una modalidad tutorizada. Quiero agradecer a la American Heart Association por el apoyo, a todos los colegas que han ayudado en hacer este curso y enfatizar también que también es un ejercicio interprogramático que no solamente es de factores de riesgo de enfermedades no transmisibles, sino que cruce todo el trabajo que hace la OMS. Y en ese sentido estoy muy contento de que tenemos acá la participación de la doctora Geri Eijkemans. Ella es la directora del nuevo Departamento de Determinantes Sociales y Ambientales para la Equidad en Salud y ella nos va a dar unas palabras de cierre. Geri, adelante.
Muchas gracias, colegas. Buenos días, good morning, goedemorgen. It's a real pleasure for me to be here with you. I have listened with attention to all this good work that has happened over the last years. Only a few years ago, in July 2020, we were in the beginning of our pandemic. I also joined this discussion when we were launching as an organization this social marketing program. And then I already emphasized the importance of social marketing in the framework of health promotion and of addressing social determinants of health, emphasizing the importance of embedding social marketing in a broader framework and context. And I heard a lot back from you on this. Meanwhile, a few years later now, we have a new director in the organization, Dr. Jarbas Barbosa, who took office this year in February, and he created this new structure. Today I'm here with you as this director of this new department on social and environmental determinants of health equity. And it's really a pleasure to be here. And I think there are a lot of things that you have mentioned where we can collaborate and work together. We do already a lot of work together with Leo and with other people in the team of the Department of Non-Communicable Diseases and Mental Health to reiterate the importance of intersectoral, interdisciplinary work as a key aspect to promote health, the importance of participation, empowerment of the population that plays an active role in advocating for health and to push government to meet their responsibilities in addressing health inequity and, through agendas that reduce the risk factors for NCDs, etc. We've heard from our collaborating center on the main aspects of the program, success that has been achieved. I'm hearing that there's already 16,000 people enrolled in this program. This is absolutely excellent. So I think we have a great future here. We also heard some of our professionals from the Ministry of Health, Aruba, Costa Rica, Panama, St. Martin. And some things I take away is the importance of identifying and understanding your audience, understanding what are the barriers, what are the drivers of behavior, and doing this through formative research, really necessary to design a successful campaign. Also, I see a lot of the challenges that countries face when we implement social marketing. It has to be part of a bigger agenda. Of course, we are always competing for resources with other priorities, but I think this is the challenge of pushing this forward, of scaling it up, of making sure that it reaches everybody is huge. I'm hearing that from you. I see a creativity that is needed and that you are using to overcome the limitations, to overcome the barriers, and of course the potential that all those trained people have in the ministry. So one of the flagship projects that our new director has put forward is scaling up the NCD action using primary healthcare. And we are working very closely with the colleagues, with Leo and Dr. Hannes, etc., to ensure that those programs integrate an equity focus in their planning, in their implementation, in the evaluation of their strategies, programs, activities. And this is very important to ensure that we increase the effectiveness of the interventions, that we really reach the people that we traditionally do not reach. And this also very much is related to the work that you're doing. And it brings me really to the importance of taking into account the context, the conditions of the populations that we are targeting, to address those social structural barriers that prevent people to really make healthier choices in life, to tackle those very structural, contextual factors that influence and determine people behavior. I've heard it from you, but I'm giving a couple of examples here. Social marketing will be effective in changing behavior if we follow a couple of conditions. Now, if we take into account those living and working conditions or situations that allow people to change their behavior, of we saying, making the healthy choice the easy choice. Income, we've seen it now. Can people really afford healthy food? Why are they be driven back to unprocessed food? This also has a lot to do with what we call the commercial determinants of health. We have, particularly in our big cities, urban food deserts where people don't have easy access to supermarkets. It's much easier to go to a McDonald's than to a supermarket. The cost of vegetables and fruit in small Caribbean islands where you would think it would be easily available, it's not. It's too expensive. So this is one of the elements we need to look at. Time. Do people have time for the cooking and the classes and the courses that we are offering? If not, how do we need what do we need to do differently to scale that up? Do people have time to exercise? Many people to survive have 2 or 3 jobs, and time is a real scarce resource. Also, the issue of availability of water. This is a big thing, and I saw that also in the presentations of some of you. I worked in the highlands of Mexico, and it was almost impossible for the people there, the indigenous populations, to buy water, because it was much cheaper to buy a soda, to buy Coca-Cola, and easier and cheaper than to buy water. So these are things, again, that go beyond the scope of the health sector, but are really important. And then looking at those populations, our migrants, our informal workers, do we really reach them? So I think it's really important to embed, and I heard you say this in different occasions, but to really think to go beyond making the people, the individuals responsible for the health problems and the health behaviors, not to blame the victim. It's important to go beyond that, to go beyond giving information, and to really work on intersectoral action. I think if we do social marketing and we do not work with those sectors that are responsible for the policies on agriculture, on trade, what do we import, how do we label, on labor, what foods are available in the workplace, what drinks are available in the workplace, with education, with housing, with transport, with social services, with economy, where are the subsidies, where are the taxes? I think it's very difficult to make progress in people's behavioral change. Knowing is important, but it's much more important to create the environment and to tackle those barriers to do that. Now, really talking about health in all policies, and this is not easy, but I think it is absolutely central that we allow people to apply the information that we're giving them. The work with municipalities. Obviously, this is very much at local level where we decide on those policies. So do we really work with the mayors, with their teams, to boost, social participation? Are we using the networks of the communities? Do we really work with the communities and understand what they want, what they need, what they can afford, and how we can be more effective in our interventions? So in short, I think social marketing integrated with other policies and other approaches is very important, a very powerful tool to improve health. Now, if it is embedded with this broader health promoting agenda using a social determinants approach, if we work in an intersectorial manner, if we work with our populations, and particularly those in situations of vulnerability that we never reach, are we taking into account these conditions of those populations when we roll out our social marketing strategies? And if we manage to really make healthier choices the easiest ones. So again, I really want to congratulate everybody who's pushing this agenda in PAHO and WHO, but particularly in our collaborating centers in our countries, because that's where things are happening. You can count on us, on our health promotion and our social determinants of health colleagues and experts in PAHO and in headquarters, but also in your country offices, to work with you on those implementation strategies of implementing behavioral change strategies in a broader context. And I'm really looking forward to being back with you in a few years and to see even more progress and even more health for everyone. Thank you so very much.
Thank you very much, Gerry, for those reflections. Very, very useful. So with that, we are coming to the end of our webinar. We have had 220 participants, which is a good number. So this topic is really of interest of everyone, and really cross-cutting and really important to work at as part of a bigger program. So just to let you know that on our webpage in a few days we will post all the presentations and the recording as well of this webinar. So please come back and consult the webpage, and you also have the links to register for the social marketing program. So hope we are in contact, and see you next time, and have a good day. Buenas tardes a todos. Gracias.